This lecture is about dissociative disorders. By the end of this lecture, you should be able to answer the question, what are the characteristics of dissociative identity disorder? You should be able to compare the traumatic, socio-cognitive, and fantasy models of dissociative identity disorder. And you should be able to answer the question, who is at risk for developing dissociative identity disorder? The DSM-5 lists a few of these sorts of disorders. This category of disorders includes the following: dissociative identity disorder, dissociative amnesia, and depersonalization derealization disorder. This lecture is going to focus primarily on dissociative identity disorder. Dissociative identity disorder used to be known as multiple personality disorder. It is not to be confused with schizophrenia, which is a completely different disorder. The first recorded case of dissociative identity disorder dates back to 1817. In 1797, a 4-year-old Mary Reynolds had a personality that was melancholy and shy. A second personality emerged when she was 19. This one was witty and extroverted. This second personality became increasingly dominant. At the age of 36, only Mary's second personality remained. So this illustrates a case where there were two personalities, one that was melancholy and shy, and one that was witty and extroverted, and one that eventually became dominant. This case is considered typical of dissociative identity disorder patients. Mary Reynolds had a very strict upbringing. The original personality was shy and sad, and the second personality was uninhibited and fun-loving. The DSM-5 criteria specify that a disruption of identity is characterized by two or more distinct personality states, which may be described in some cultures as an experience of possession. The disruption in identity involves marked discontinuity in sense of self and sense of agency, accompanied by related alterations in affect, behavior, consciousness, memory, perception, cognition, and/or sensory motor functioning. All of these signs and symptoms may be observed by others or reported by the individual. The individual will often experience recurrent gaps in the recall of everyday events, important personal information, and/or traumatic events that are inconsistent with ordinary forgetting. As with other DSM-5 criteria, the symptoms have to cause clinically significant distress or impairment in social, occupational, or other important areas of functioning in order to be considered a disorder. And also, the disturbance is not a normal part of a broadly accepted cultural or religious practice. It's important to note that in children, the symptoms should not be better explained by imaginary playmates or other fantasy play. That is, a child playing with imaginary playmates should not be considered necessarily to have dissociative identity disorder. There are some common elements to dissociative identity disorder. For instance, almost every authentic case of dissociative identity disorder involves some severe childhood trauma. The theory is that under severe stress, some children allow their normal self to retreat into unconsciousness, while the second self emerges to absorb the punishment or deal with the trauma that they are experiencing. This is known as the post-traumatic or traumatic model of dissociative identity disorder. The stressor is quite often either severe discipline or sexual abuse. Dissociative identity disorder is often conceptualized as the most severe, chronic, complex childhood onset form of post-traumatic stress disorder. There have been several best-selling books that became popular movies about dissociative identity disorder. Two of them are The Three Faces of Eve and Sybil. Beginning in the 1980s and shortly after the publication of those two books and their conversion into movies, the number of cases of DID that were diagnosed began increasing in frequency quite dramatically. So, for example, between the years of 1944 and 1970, there were only 8 new cases. Between the years of 1970 and 1979, there were 39 new cases. But between the years of 1980 to 1989, there were 212 new cases. Between 1990 and 1999, 391 new cases. And then there seemed to be a tapering off in the early 2000s. So from 2000 to 2009, there were only 179 new cases. In 1994, Nicholas Spanos argued that dissociative identity disorder is a social construction. He pointed out that the syndrome had changed since becoming popular in the 1980s. Older cases of dissociative identity disorder involved 2 to 3 personalities, where the newer cases commonly involved a dozen or more. Moreover, only a small number of psychiatrists had actually reported seeing any of these cases. Spanos argued that dissociative identity disorder is a form of role-playing between patients who are seeking attention from a therapist and therapists who have an urge for discovery. He called this a socio-cognitive model of dissociative identity disorder. There is a third model of dissociative identity disorder called the fantasy model of dissociation. According to the fantasy model of dissociation, there are antecedent variables that, through mediators and moderators, lead to the experience of trauma and dissociation. So, for example, some antecedent variables would include suggestive influences, so for example, leading questions, hypnosis, or repeated questioning, media and sociocultural influences, coexisting or ambiguous psychological symptoms, highly aversive events, so for example, childhood abuse, extreme loneliness, or isolation. And the mediators and moderators could include fantasy proneness, fantasy activity, suggestibility, high negative emotionality, cognitive distortion or failures, sleep disruption, social support, developmental level, dysfunctional family relationships, and genetic or biological vulnerability. In terms of trauma and dissociation, the end result would be self-reports of trauma, in some cases false memories of trauma, the acceptance of implicit and explicit suggestions, and dissociative experiences and symptoms. So who gets dissociative identity disorder? Well, it occurs in approximately 1 to 3% of the general population and about 12 to 16% of psychiatric outpatients. It's thought to be more common in females. Approximately 50% of all new cases originate from within the US or Canada. And it has been suggested that 67% of all new cases in the US in 2000 to 2010 originated from just 5 research groups. There are psychophysiological differences between the neutral identity state, which often occurs in dissociative identity disorder, and the traumatic identity state, which often occurs in dissociative identity disorder. That is, there tends to be at least one identity that is neutral in nature, and one identity that is dealing with the trauma that the person experienced. And when you expose the person to neutral or trauma-related memory scripts, what you will see is that in the latter case, that is when the two personalities listen to trauma-related memory scripts, there are distinct differences in the psychophysiological variables that the two different identities exhibit. In all cases, the traumatic identity state will show greater psychophysiological arousal in response to the trauma-related memory script than the neutral identity state.